Hello and welcome to the 2018 ABR Non-Interpretive Skills Study Guide Review Series. This is David Larson at Stanford University, and thank you for joining me again today. We're continuing where we left off in the study guide last time, and today we are now at section 4.1, Practical Safety Applications in Radiology, focusing on MRI. This one may be a little bit shorter, so we'll go ahead and get started. Question number 1, what is the most important thing to remember about MR safety? This is definitely a what am I thinking type of thing, but I think it's reasonable. The most important thing to remember about MR safety is the magnet is always on. So if you don't know this or you forget this, then that's a big problem. You need to know that the magnet is always on. Most important thing to remember. Next question, who tends to be at highest risk for creating unsafe conditions in MRI? Okay, so the people who tend to be at high risk for creating unsafe conditions are personnel who do not regularly work in the MR environment. So obviously patients, but also physicians and nurses, non-imaging personnel, especially those who may enter during a code situation, security and cleaning personnel, and patient family members. And these often may be overlooked in the screening programs because you're so focused on the patient, you may forget about the family members. So those are the patients at highest risk, those who are typically not in the MR environment, so you need to watch them carefully. Next question, describe the different MR zones. All right, so the MR zones refer to the areas of around the magnet that basically as you get closer to the magnet, then the risk increases. So it describes both the proximity of the magnet as well as the risk and also what should happen within those zones. So zone 1 is essentially unrestricted access and it includes all areas freely accessible to the public. So you are now likely sitting in a zone 1 wherever you are. So this is just any public area. Zone 2 is the patient screening and preparation area. So this basically is the interface between the public area, which is zone 1, and the strictly controlled area, which is zone 3. This is that interface area where you may greet patients, obtain history, screen patients for MR issues, etc. So zone 3 then is that first area of restricted access. So this is where you get into areas where there's a potential danger of serious injury or death. The scanner control room, for example, is typically located in zone 3. Access must be strictly restricted and under the supervision of MR personnel. So if you have a patient going through, they've got to be escorted and supervised at all times. And also restriction must be in place, such as locks or pass key system. In other words, people shouldn't be able to get into a zone 3 unless they are supposed to, and otherwise it should be locked out. And then zone 4 is the actual MR scanner magnet room. So this is the highest risk area, and it should be clearly demarcated and marked as potentially hazardous and should be under the direct observation of MR personnel whenever anyone is around. So this is the magnet room. That's the highest risk, zone 4. Next question, between which MRI zones does the major transition happen? So we alluded to this before. The major transition happens between zone 2 and zone 3. Personnel working within zone 3 should have specific education on MR safety and pass MR safety screening processes, and all other individuals entering zone 3 should be appropriately screened. So that's what zone 2 really is for. That's the purpose of it, is to prepare patients to, or anyone to enter into zone 3, make sure they're screened, make sure you've taken care of everything you need to in zone 2 before they go into zone 3. Next question, describe the process for MR screening. MR screening begins with a focused history to identify potential metallic foreign objects and medical implants, and then it may be supplemented as needed by radiographs or review of previous imaging studies such as CT or MRI in the area of question. And when an object or implant is identified, its MR compatibility or safety should be assessed specific to the strength of the magnet. So again, it starts with a history, thorough history of any metallic foreign objects, supplement as needed. Next question, what are the categories describing MR compatibility of medical devices? All right, so there are basically 3 categories. Those that are MR safe, that are non-hazardous in all MR environments. those that are MR conditional, meaning they're MR compatible in specific conditions, and MR unsafe, and they're contraindicated in any MR environment. Next question. Ferromagnetic objects should be restricted from entering which zone? The answer is zone 3, wherever practical. All MR sites should have a handheld magnetic or ferromagnetic detection device, which allows for testing of external objects in some superficial internal implants, so that they can test that hopefully before they go into zone 3. Occasionally, ferromagnetic and MR unsafe objects may be permitted in zone 3, but they must be secured at all times and under the supervision of trained MR personnel. Next question. What is the major risk of large metal objects entering the scanner room? Well, hopefully this is fairly obvious, but primarily it's projectile injuries. Often these are from oxygen tanks or anesthetic gas tanks. It's not uncommon to see a wheelchair or even a gurney, but any metallic object that then becomes a projectile as it goes into the magnet. Next question. How should screening be done when patients are unconscious or unable to provide a reliable history? So you basically do the best that you can. You rely on other sources, family members, medical records. If it's an emergency, you may even have to rely on surgical scars or other evidence of surgery. So you're really balancing the urgency of the examination with the level of uncertainty of the screening process. So if you have an unreliable screening process and not great information otherwise, they need to really rethink the whole imaging strategy. Do you really need the MRI? Can you get away with a CT or an ultrasound? Or can you wait until you can get a more reliable history? Next question. What is the point at which the magnetic field begins to affect electromagnetic devices such as pacemakers? That point is the 5 Gauss line, and that should be marked on the floors or the walls, especially when it extends beyond the walls of the MR scanner room. So there needs to be a 5 Gauss line marked around the scanner. And you need to remember that the magnetic field is 3-dimensional, and so this may actually extend through the floor and or the ceiling into adjacent floors. So this is something that when a scanner is installed, there's a lot of attention that's paid to the 5 Gauss line because it has implications for who can be in that area and how that area can be managed. Next question. What potential problem poses the major risk for a ferromagnetic aneurysm clip in MRI? And what can happen to that clip? That's the biggest problem. In general, it's the rotation of the aneurysm clip. When it goes into the magnet, it's subject to varying amounts of translational and rotational forces, and so if it rotates a certain way, obviously it can cause big problems. Next question. An MRI has been ordered for a patient with an aneurysm clip. The MR compatibility is unknown, but the patient has safely undergone MRI in the past. Is it okay to proceed with the MRI? The answer is no. You still need to determine that the implant is MR safe or at least conditional, because variations exist between scanners, and you may have just gotten lucky in the past. So no, just because they had they underwent MRI safely in the past does not mean that nothing could potentially happen in the future. Next question. What potential problems can occur in patients with cardiac implantable electronic devices undergoing MRI? So major problems are failure to pace, induction of ventricular fibrillation, or heating of cardiac tissue adjacent to the leads. Next question. What precautions should be taken for patients with implantable cardioverter-defibrillator devices who must undergo MRI? If they have to undergo MRI, then radiology and cardiology personnel should be immediately available throughout the procedure. And also the crash cart should be immediately available in case a significant arrhythmia develops. So basically you need to be ready for something to go wrong if you have to go ahead and get the MRI. Next question. What fetal risk has been shown for pregnant women undergoing MRI? So here again, we're talking about undergoing the MRI. We're not talking about contrast, for example. And the answer is none has been definitively shown. No risk has been definitively shown for pregnant patients undergoing MRI, either to the patient or to the fetus. And so, in general, again, this is somewhat controversial, but for the most part, no special consideration regarding MRI is recommended during pregnancy. However, of course, it's impossible to completely exclude all possibility of risk, so you may wish to delay the MR until after pregnancy if possible. And when it comes to pregnant healthcare workers, they are allowed to work in the MRI environment during all stages of pregnancy, but it's recommended that they not remain within zone 4 during scanning. Next question. What may cause burns in patients undergoing MRI? So burns are generally caused by loops of metallic wire, by patches of metal, or other electrical conduction circuits. And these may be rapidly heated by radiofrequency pulses during normal operation of an MRI system. So anytime you have that circuit. Certain transdermal patches may contain aluminum and other metals that may create a circuit. And so you've got to prevent loops or metallic patches from touching a patient's skin during routine scanning. And just note that even having legs crossed or arms crossed can create a circuit, especially if the patient begins to sweat. It becomes more conductive. So anytime you have a circuit, it can cause burns. Next question. What happens when a magnet is quenched, when an MRI magnet is quenched? In an MRI scanner, the main magnetic field is maintained by bathing electromagnetic coils in large volumes of extremely cold helium. That allows the superconducting current, which allows this level of magnet to be able to be maintained, that magnetism to be maintained. So a quench occurs when segments of the coils are heated and they're no longer superconducting, which then becomes further heated, which then increases or decreases its superconductivity, which creates this vicious cycle basically. So then you can have a rapid change of state of liquid helium into gas. And you're talking about a 760-fold increase in volume. So it's essentially explosive or nearly explosive. So to accommodate the explosive force of rapidly boiling helium gas, a quench pipe is designed to allow helium to vent into the atmosphere. So there is that failsafe. However, if the quench pipe fails, the helium could flow into the magnet room. And if it does, then helium would flow into the room, which would displace oxygen to the floor, which would create a risk of asphyxiation. It would form a fog, making it impossible for people in the room to see, and the positive pressure could prevent opening of inward swinging doors, causing entrapment. So those are the risks of when a magnet is quenched, especially when it's accidentally quenched. Next question. When should an MRI magnet be intentionally quenched? Well, it should be intentionally quenched in the case of injury or an emergency situation due to the magnetic field. For example, when personnel are pinned to the magnet by a ferromagnetic hospital gurney, that really necessitates turning off the magnetism. So not necessarily any time that there's something that is pinned to the magnet. For example, if you have an object that's pinned to the magnet, but the personnel are not at risk, then you don't need to quench the magnet. But it's only when there's an emergency situation that will be mediated by turning off the magnet. A quench can be initiated by pressing a quench button, and you should note that a quench can also occur spontaneously in the event of equipment failure. So something to be watching for if the magnet can quench. Okay, that ends this section. We'll go on to the next section in the next video. Thank you again for watching. This is David Larson reviewing the 2018 ABR Non-Interpretive Skills Study Guide.